Good morning.
Good morning.
We have a few minutes before we start, so I'm going to do some research here and get started before we get started, okay?
That's just fine. I'm gonna go get a cup of coffee. You need one?
I need a refill of my tea, so I'll go get one too.
You go get one and I'll be back. Down in Centennial. So that's where we used to do all of our dance recitals and all of our dance practices. So you guys shared those dance spaces.
I've
With our
done
dancing.
I've done some exercise sessions, but dancing,
Well, yeah, I don't think they dance there, but it's just that's where they leased out space at our dance academy. So
I
when
see.
Parkinson's Pointe first started, that's where it was housed. And then when COVID hit, I don't know if they're actually using that space anymore. Are you?
The one in Aurora.
The one in the tech center, right north of the county line.
You know, I'm only familiar with the one in Aurora, so I
Okay.
don't know.
I gotcha.
But I
think
see
they moved.
Dr. Mian has joined us.
Good morning. How are you?
Good morning. I'm Adrienne, and I'm working with Dr. Roberts on these Friday sessions, so I'll be the moderator for today's session.
Great.
And
Thanks for
just
having me.
want to make sure that if you need to share your screen, that you have that ability. I was having some trouble making sure that the settings were appropriate for sharing screen.
Sure, I can try it right now. So I have some slides, and it looks like that's sharing.
I can see
Okay.
them.
Perfect. I can see them fine.
Yeah, my hope was, I think we have an hour, is that right?
Yes, we have a hard stop at 11:30. There's another group that needs the Zoom session after us.
Okay, my hope was that maybe I go for 35, 40 minutes, and then we have plenty of time for questions or discussion after that, if that's okay.
Okay. And I see some people are joining us. Good morning. Okay, very good. So I have I am the proud recipient of a new e-cycle. According to your bio, it says that you like to do bicycling.
Yeah, I don't have any e-bikes. What do you think of it?
I think it's the best thing since sliced bread, actually. I can now go twice as far and have twice as much fun on my bicycle. I've just taken it for 2 drives so far, but I just love it. It's really,
Yeah.
really, really good.
I have a patient who's been telling me he got one and he modified it so he can go like 40 miles an hour, and he takes it mountain biking. And I told him, please do not do that.
That was the warning I was gonna give you too, because I was talking with some folks yesterday at the hospital, and they're like, people go way too fast on these e-bikes and they're gonna get hurt. So don't go
Road
too
is
fast.
one thing, but don't try to take it down a mountain, I'd
Yeah.
say.
No, I'm too timid. I like those nice, safe bike paths, you know, the one underneath the trees. So
No, those are lovely. Yeah, they've got quite a network out here in Colorado, so we've got a lot to explore.
good morning, everyone. We have more people joining us, and we're glad to have you today. We'll just give everyone a few more minutes to join in. Yep, there's a bike path that goes from my house all the way to Cherry Creek Reservoir.
Mhm.
And it's 14 miles, and I'm looking forward to, it's 14 miles downhill, and then you have to go 14 miles uphill to go home. But I think with my new e-bike, I'll be just fine.
Yeah, is it the one that goes along the river, or which route are you talking about?
It's Cherry Creek,
Uh-huh.
the trail.
Yeah.
Yeah, it's really, really something. I love Aurora for that reason. They really dedicate time and budget for bike trails.
Yeah, it's lovely. I think probably you'll find more luck on the weekdays. I think on the weekends it can get kind of crowded, and you're weaving back and forth around people sometimes.
That's right. That's why I like Tuesdays and Thursdays before 9 a.m.
Mhm. Yeah, pretty quiet then, I imagine, huh?
Yes. So more people are joining us. This is wonderful to have this many people joining us. We have a great session planned for today. And let's see. We have another minute or so. If you could look at your Zoom settings, and if you would like, please to mute yourself. We have, thank you very much. Sometimes that background noise gets, we can hear that more than we can hear this people speaking. So thank you for muting. Today is June the 25th, and just in case you were wondering, it is National Take Your Dog to Work Day, and it is also National Handshake Day. And for those of us in the Parkinson's world, that may mean one thing to us and another thing to other people. So that's a Parkinson's joke there. Those are far and few between. But let me take a minute and introduce our speaker for today. Dr. Mian is joining us.
Young guy.
This is the Parkinson's Pointe Friday Educational Center session. And my name's Adrienne Bradshaw, and I help Dr. Meredith Roberts-Lowe with this monthly session, and it's being recorded today so that others can see it. Maybe their schedules don't permit viewing it today and participating today. So let's start off with some housekeeping. With such a good turnout here, I may need to ask you for your name and email address if I don't have it. Dr. Lowe needs that information for her records. And so I'll be checking in with you if I need any more information from you. Hope everyone's well today. Let me start off by reading Dr. Mian's biography. Everybody ready?
We are.
Can you hear me okay?
Yep.
Okay, let's start off. Dr. Matthew Mian is a neurosurgeon in Denver, Colorado with the Pointe Neurosurgery and Spine Center. He is the director of functional neurosurgery at Swedish Medical Center, and that hospital is located in the South Metro Denver area. Dr. Mian grew up in Michigan and North Carolina, and he studied biomedical engineering and math at Duke University, and then earned his medical degree with honors from a joint program between Harvard and MIT. While in Boston, Dr. Mian developed an interest in cognitive neuroscience, and his studies were published in prominent journals.
Wow.
In Nature, the Journal of Neuroscience, and Cerebral Cortex. Dr. Mian has practiced in Colorado since 2019. Welcome. I hope you like it here, and it's a great place to live. And he also takes an active role in patient advocacy. He's a member of the Parkinson's Association of the Rockies, the Epilepsy Foundation of Colorado, and the Facial Pain Association. Dr. Mian is passionate about minimally invasive neurosurgical therapies. He prioritizes clear and honest discussions with patients. His practice focuses on bringing the latest advancements to the operating room, including technologies like robotic neurosurgery. Boy, I can't wait to hear more about that. And in your free time, Dr. Mian, what do you enjoy doing here in Colorado?
I like enjoying the outdoors. So we talked a little bit about cycling, but also hiking and some photography as well. So I ski, but I'm not that good.
Have you been up to Copper Mountain?
I haven't been to Copper Mountain, no, not that one.
That's my favorite.
Okay. I'll
Great
have to try it
scenery.
out this season.
Yeah. Okay, let's turn it over to you, Doctor. And our topic today is, well, I'll just let you introduce the topic.
Sure. I'm going to go ahead and share my screen. And are you guys able to see that?
Yes.
And can you see my mouse on the screen when I move it around?
Yes.
Okay, great. So, thank you for the introduction. Thank you for the invitation to speak. And of course, thank you all for making the time. This is something that I'm very passionate about. I, of course, as mentioned, am a surgeon who focuses, among other things, on surgery for Parkinson's disease. And so today, I'd like to give an overview of a bit about Parkinson's. We already kind of went over this, but a little bit about the background on Parkinson's disease. Focus a lot of the time on surgery for Parkinson's disease. Who do we do it for? How does it work? When do we do it? That sort of thing. And then finish up by talking about some of the exciting developments or advancements that we have in surgery for Parkinson's disease that are changing patients' lives today and hopefully in the near future.
So, Doctor, will we have a chance for questions later on?
Absolutely. So my intent is to try, I know we have an hour, so to try to go maybe 35, 40 minutes and then to leave the remainder of the time for questions. So we should have plenty of time. So some of this may be familiar to all of you, but I think it's sometimes helpful to review it or to hear somebody else describe it. Parkinson's disease is actually very common. It affects about 1% of people over the age of 65, which means that in the United States, there's something like 1 million people who are affected. We think that it's due to a gradual loss of cells in the brain that produce a chemical called dopamine, which is a neurotransmitter. It allows nerve cells or neurons to signal to one another. We actually don't know why these cells disappear over time, but we do know that the loss of those cells affects different parts of the brain, and among them, a part of the brain called the basal ganglia. And we think that's what gives rise to many of the movement symptoms of Parkinson's disease. So this is where a lot of these dopamine cells live. It's a part of the brain called the substantia nigra. It's a deep part of the brain called the midbrain or the brain stem. And if you slice it kind of like this in the photo, it kind of looks like a Mickey Mouse face. But in Parkinson's disease, this dark stripe here gets faded away. And you can see that on special stains for dopamine. So this is a patient who's unaffected by Parkinson's disease. And you can see how this stripe is faded in someone with Parkinson's. And these are these dopaminergic cells that have a dark pigment inside of them. Now, we can see this on a scan sometimes with what's called a DAT study. So this is a study that looks at dopamine uptake in the brain. And an unaffected patient, you might see a relatively symmetric distribution of dopamine, and then a more disorganized pattern as Parkinson's disease advances. This is not a perfect diagnostic test for Parkinson's, but it's something that we sometimes use if it's unclear or if there are other diagnoses that we're thinking about. As I mentioned, dopamine, so it's a chemical that one neuron will secrete or emit to try to signal to a nearby neuron to conduct an impulse. And so when dopamine is reduced, these neurons basically just have trouble talking to each other. And it gives rise to, the primary motor symptoms of Parkinson's disease with which, many of us are very familiar, intimately familiar. So bradykinesia or slowness of movement, rigidity or stiffness, of course, the resting tremor of Parkinson's disease, and then trouble with posture or balance. There are a variety of effects elsewhere in the body, of course, related to the lack of dopamine, but these are the movement types of symptoms that we often see. Now, it turns out that the movement symptoms, the trembling, the rigidity, the slowness, are actually relatively late manifestations of Parkinson's disease. So by the time we see those, a lot of those dopamine cells have already been lost. And in retrospect, sometimes patients have had symptoms for 10 or even 20 years that really didn't get a lot of attention because they're not as visible. So things like trouble with sleep or something called RBD, where patients will vividly act out their dreams during the night while they're asleep. In many cases, patients have had constipation for a very long time. These are kind of non-specific symptoms sometimes, so lots of things can cause constipation, for example. And so it's often not until the movement symptoms develop that patients are actually diagnosed. We, of course, have dozens, really, of medicines that are aimed at treating different aspects of Parkinson's disease. The mainstay of medical therapy for the movement symptoms is basically replacing the dopamine that's been lost with different oral formulations. The most common of which is Sinemet, which is a combined form of levodopa and another medicine that inhibits the metabolism of levodopa outside of the brain. But there's a variety of other medicines. Some of them are listed here. They're all aimed at using different mechanisms, trying to increase the amount of dopamine that's available for nerves to signal in the brain. And importantly, as many of you may be familiar with, the level of dopamine in your blood, in the brain, correlates with the severity of movement symptoms at any given time throughout the day. So in Parkinson's, I often try to draw a distinction between two different states that someone can be in relative to their movement functions. The on state is a state where your movements are very good. They're fluid. You may not have much rigidity or much tremor. This is your best movement function during the day. And then, of course, as you may know, there are times during the day where your movements are less good, or your tremor may be worse. And we refer to this as an off state. And The difference between an on and off state at a biochemical level relates a little bit to where, how much dopamine you have in your brain. And so early on in Parkinson's disease, when a patient takes a dose of oral dopamine, Sinemet, we see a gradual increase in the level of dopamine and therefore a gradual improvement in their motor function that later decays over a few hours. So a patient early on in the disease after a dose of Sinemet may enjoy several hours, 4, 6, even longer hours where their movement functions are very good. They're in an on state. But what happens is as Parkinson's disease progresses and more of those dopamine cells die in the brain, patients become increasingly brittle. So you spend less time with that good motor function that we want to maximize and more time either off, meaning you don't have enough dopamine in your system, or even
Dr. Mian, we lost you.
Oh.
Can't hear you at this point. Does anyone else hear Dr. Mian?
Nope, he's frozen on mine.
Yeah, he froze.
uh-oh,
Dr. Mian,
There you go.
are you back?
I'm back. We still,
Okay.
There
good.
we go.
you see my screen
Okay.
again?
Yes.
Yes.
Okay, technical glitch. But so as I was saying here, later in the course of Parkinson's disease, fluctuate pretty rapidly during the day in a place where they don't have enough dopamine and a place where they have too much dopamine. And they may not spend a long time in the sweet spot here where their movements are relatively good and they don't have these unwanted, uncontrollable writhing movements called dyskinesias. So the goal of our therapy and the goal of surgery, as you'll see here in a bit, is really to maximize this time that you have where your movement function is good.
It's good.
So we know that patients who start taking levodopa or Sinemet over time can develop what we call motor complications of Parkinson's disease. And I've listed the main ones here. So the first we've kind of already talked about, that medications after taking a dose can start to wear off quickly, so that you may have to take 5 or even 6 times your medication during the day. I have patients who, during the course of a day have to essentially take a fistful of pills. And then alternately, when the medicine is at a very high level in their system, they can develop these unwanted movements called dyskinesias. And then another common motor complication of Parkinson's is something called medication-resistant tremor. So that despite medicines, the tremor is still pretty bothersome and persistent. We know statistically that this affects about half of Parkinson's patients, and typically it shows its face around 4 to 6 years, an average of about 5 years after starting medications for Parkinson's disease. So that brings us to surgery, and this is where I want to focus our attention for most of the discussion today. But when do we think about surgery? What is the surgery? Why do we do it? And what can a patient expect? And the short answer here as to who should consider surgery is we should really at least engage a discussion for any patient with Parkinson's disease who has developed one or more of those motor complications that I showed you before. Now, surgery for Parkinson's used to look a lot different than it does today. This is a procedure that we used to do called a pallidotomy. It's pretty rare nowadays. But in this procedure, a little probe was inserted into the brain and a part of the brain was burned called the pallidum. You can see the little lesions on this MRI scan where this patient had his or her pallidum burned. And for reasons that we didn't quite understand at the time, this seemed to make the symptoms of Parkinson's disease better. Michael J. Fox, for example, he didn't have this surgery exactly, but he had a related surgery where part of the brain was burned. But what we discovered is that over time, there are different ways of treating the movement symptoms that are not irreversible and don't carry as much risk. So something called deep brain stimulation, or DBS, which is what we'll focus on today, was studied in the 1970s and 80s. And essentially what it is the delivery of very targeted pulses of electricity to the nervous system, to the brain, in a way that interrupts the abnormal brain rhythms that we know cause some of the symptoms of Parkinson's disease. This had advantages over the procedure I mentioned before because it is flexible. We can change the settings of the stimulator over time, and it's reversible. It doesn't cause irreversible damage to part of the brain, which can sometimes cause side effects. It was approved over 20 years ago, initially for essential tremor and later for Parkinson's disease. And it's now very much the standard of care for patients with Parkinson's disease across the country. There's been hundreds of thousands of patients implanted. This is an illustration of what the system looks like. So an electrode that enters the brain, usually from the top of the head, a wire that runs behind the ear and then down to a small battery pack that's much like a pacemaker that sits beneath the collarbone. And this is a 3D reconstruction I made from a CT scan from one of my patients. This wire is really just over 1 millimeter wide. It's quite thin. And then the wire runs underneath the skull and, underneath the scalp, just over the skull. And it's later sent down under the skin down to that battery pack. These are examples of what the implants look like. They're getting smaller and smaller all the time. You can see a quarter there for a size comparison. And the most important thing is what kind of benefits does it provide the patients who get it. We're blessed in the field of DBS because we have more randomized controlled trials of this therapy, which is the gold standard of medicine, than really anything else in all of neurosurgery. So I'm just going to show you a little bit of data from these, but this is a study that looked at improvements in functional status. In other words, the ability of patients to do things around the house. And you can see that before surgery, for these patients, there was a very big difference in their scores if they were off medicine or on medicine. And that difference largely disappears over time, and that persists for 5 years or more. This study was only for 5 years, but we think that the effects of DBS continue to work for patients. And so this is one of the nice things that DBS does, is it eliminates or at least reduces the dramatic differences between when you're on your medicines and when you're off. So it takes those wild fluctuations and kind of smooths out the day. And what that translates into for patients is more of their best motor function during the day. And on average, the large studies suggest that there's an additional 4 to 5 hours of your best movement function per day. So when you think about the number of hours that we're awake, an additional 5 hours is usually a very meaningful change for most patients. And then most importantly, pretty much across the board in all aspects of life, patients who get DBS therapy report that their life is improved. Their quality of life is better than it was before surgery. And personally, I think this is the most important slide. So the patients feel that their life is better after the surgery with their enhanced function and activities of daily living than it was before. This is, you can find countless examples on YouTube. This is just a quick video I shot recently of a patient. This was actually a tremor patient, but the principle is the same for patients with Parkinson's. This is a patient you can see initially. I think we might lose the sound when I turn this video on, so I'll describe it first. But he has a pretty bad tremor when the DBS is turned off, and then we turn it on and you can see the tremor melt away. Now this is off. This is off. Wow. So for most patients, the ability to reduce the tremor like that makes a huge difference. So just to summarize the benefits of this therapy, it improves functional status and by extension, patients' independence. It provides them more good motor function or on time per day, again, about 5 hours. It reduces those symptoms that we talked about related to the movement features of Parkinson's disease. It often frequently allows patients to reduce their medicine doses, to take lower doses and to take them fewer times a day. And most importantly, patients report that their quality of life is better. So what do I tell a patient when I see them in the office, just to try to set expectations? There's some things that I think are really important to touch on. So the first is that DBS is very effective for the movement symptoms of Parkinson's disease. So tremor, slowness, gait and balance. It's not really effective for the non-movement symptoms. Okay, so if you have problems with sleep, problems with memory, problems with constipation, sense of smell, these things we don't expect to get better with DBS. DBS is not a cure. Unfortunately, right now in 2021, we don't have a cure for Parkinson's disease, and Parkinson's disease will continue to be a progressive disorder. But patients who get DBS therapy typically describe that their symptoms are set back by about 5 years. So they feel like they did about 5 years before. And then DBS provides you more of your best motor function during the day, but it doesn't usually make the quality of your best function any better. It just gives you more of it. So who do I think about for DBS surgery if I'm seeing them in the office? I usually look for patients that have had the diagnosis for several years, and we'll talk about why that is. That they've had a good response to Sinemet, okay? And that's because the best predictor of who gets better with DBS is who gets better with Sinemet. Now, as we talked about, sometimes the response to Sinemet can decay or get worse over time. What we're really looking for is that a patient at some point in their disease has been responsive and had a good response to Sinemet. And then patients, of course, who have developed what we discussed before, which are those motor complications. But the greatest barrier that I face as a surgeon is that most of the patients who are eligible for this kind of surgery actually never get referred to meet a surgeon. And I think it's really sad and unfortunate when I meet a patient, who's had Parkinson's for a long time and is maybe by the time they meet me past the point where this kind of therapy would benefit them, or they've lost many of the years where they would have had benefit simply because they hadn't heard of it or no one had considered sending them to a surgeon. And so that's what I'm trying to address with educational sessions like this one. So when should a patient think about DBS? There's evidence, and we don't have to drill down too much on this, but doing it a little bit earlier in the disease course will benefit patients rather than waiting until patients are really far along. I don't want to see patients when they're at this stage of the disease where they're not able to function independently anymore, they're wheelchair bound. We want to focus on those much earlier stages of the disease where they have many years in front of them that they stand to benefit from the therapy. Now, why, you might ask, if earlier is better, why don't we implant right after somebody is diagnosed with Parkinson's disease? I think there are two main reasons. The first is that some patients have excellent responses to medicines that last a really long time. And in that case, we want to avoid invasive treatments like surgery as long as we can. As it turns out, some patients never end up developing those motor complications that we talked about. And so we always try in medicine to start with the lowest hanging fruit or the least invasive options first. The second is that some patients with symptoms of Parkinson's disease over time will actually declare themselves to have another related disorder. And there are several examples of these that you can see on this page. So MSA, or multiple system atrophy, PSP, CBD. These things are like Parkinson's disease, so we call them Parkinson's mimics or chameleons, but later on they have different features and different courses. And what we know about these disorders is that unlike Parkinson's disease, patients don't really have great or long-lasting responses to DBS. And so we try to avoid putting these kinds of patients through surgery. And sometimes you have to wait a few years to understand whether it's Parkinson's disease or one of these. because very simply right now, as I mentioned before, we don't have a great 100% accurate blood test or scan that allows us to confirm a diagnosis. So now a little bit about the nuts and bolts of DBS. How do we do this? What is the experience like for a patient? We have two targets in the brain that we aim at. One is called the subthalamic nucleus, which is this little orange blob here. The other one is called the globus pallidus. That's something that I talk about in detail with your neurologist before we decide on. I think the big picture message is that there's not really convincing evidence right now that one of those two is better than the other. There are minor differences that might make us lean towards one or the other in individual patients, but the biggest study we have of this actually comes from the Veterans Administration here in the United States. And from a 30,000-foot view, they didn't see big differences between patients who were randomized to one of these targets or the other. So what is the experience like for a patient? I kind of wanted to walk through this process step by step. It starts, of course, with a diagnosis of Parkinson's disease, and that can be made sometimes by a primary care doctor, but usually by a neurologist. And then typically medications for Parkinson's start. And after several years, like we talked about half of patients will develop those motor complications. Ideally, the development of those complications would trigger a patient meeting someone like me, a surgeon. And meeting with a surgeon is part of the surgical evaluation, but there are a few other pieces that I wanted to review. One on-off test, or sometimes this is called a levodopa challenge test. And what that is an evaluation, sometimes with a neurologist, sometimes with a physical therapist, but a detailed motor test or movement test of the patient, first off medicines and then on medicines. And what we're hoping to see is that the medicines actually improve the movement symptoms of Parkinson's disease, that there's a difference between the on and off states. And the reason we do that is very simply that, as I mentioned before, the best predictor of who gets better with DBS is who gets some benefit from cinema. I also have the patients meet with a neuropsychologist. And a common question is why do I need to meet with a psychologist if we're thinking about surgery? I think this is a really important step and one that allows us to do the surgery safely. But the reason is that Parkinson's disease, as it progresses, can sometimes cause problems with thinking and memory. And in certain cases, DBS can make those cognitive weaknesses worse. And so by meeting with a psychologist, we try to establish a baseline, understand if you're affected by some of those cognitive changes, how bad those cognitive changes are, and then optimize the surgery for you. So sometimes that means picking a different surgical target. Sometimes it means maybe we just treat one side of the brain at the time, but it allows us to customize the surgery and to make it as safe as possible. And also importantly, many insurance companies also require this. So to be responsible about this, we try to get psychological evaluations in all patients. And so after some brain scans that allow me to plan the surgery, we actually perform the procedure. So the procedure in most instances is performed in two parts or two stages. The first stage is the bigger of the two surgeries. That's where the wires are implanted into the brain. Usually involves staying in the hospital for one night. And then if you're feeling well in the morning, you can go home. And then the second stage is a smaller surgery. That's where we place the battery pack under the collarbone, much like the pacemaker, and that does not need any hospital stay. That's an outpatient surgery. And typically we allow patients a week or two to recover after the first surgery before we do the second one. I think I have some pictures here of what the surgery is actually like. So I do the surgery using a specialized robot that I'll show you in a bit. But what it means is that before the surgery, I've made a plan using a 3D model of your brain of where I'd like to place my electrode. You can see it as this dark line here. I've selected the target in your brain. On the day of, I'll set up the robot. This is the patient's head here. This is a big CT scanner that we can use to check the position of the probe. And here's me setting up the robot that I used to introduce it. And I'll talk a little bit about what the robot does and why I like to use a robot here in a bit. It's just some more pictures from the surgery. And then I perform a CT scan in the operating room that allows me to confirm that I place the electrode exactly where I want to. So this was my intended trajectory here. And you can see that the lead, which is the bright white spot here, ended up pretty much exactly where we were aiming. And then I like to do testing of the patient in the operating room. This is something that probably adds about 10 or 15 minutes to the procedure, but it allows me to be confident that we've hit the right spot in the brain and the effects that we see when we turn the device on are going to be what we want, and that we're not going to have any side effects. So I think we have a video here. Again, we might lose the sound during the video, so I'll explain it beforehand, but this is a patient where we're making adjustments to the probe while the patient is holding his hand up, and we're looking for changes in his tremor, in his rigidity, and the other symptoms that we're trying to address. And often the changes, I mean, they occur on the order of seconds, and it's quite dramatic. I've had a number of patients who frankly start crying in the operating room because the difference they see is so striking and so immediate. But that intraoperative testing, I think, and it allows us to understand that we've hit exactly the spot we want to hit in the brain. And then in the second procedure, again, this is a pretty brief procedure that's 30 or 40 minutes. I take the end of the wire that we left under the skin from the brain procedure, and I send it under the skin all the way down to the upper part of the chest where we put in the small battery. Common question I get is, what are the risks of DBS? The main risks that I mentioned to patients are these. So the first one is infection. This is an implant. It's a piece of hardware in your body. And so like any other piece of hardware, it's at risk for getting germs on it. And so I am scrupulous about sterile technique in this operation. I give patients 2 antibiotics to try to prevent infection. I clean the skin with 2 different cleaners. And so my infection rate is quite low, but this kind of thing can happen. Another risk is really just that the therapy doesn't meet a patient's expectations. And that's why I try to be super clear in these discussions ahead of time so that patients know what kinds of things might get better and what kinds of things won't. Because I can do a fantastic surgery, but if a patient thinks that this is going to be a cure for Parkinson's disease, then he or she is going to be disappointed. And I don't like to set up that kind of expectation. Again, another risk of DBS is cognitive changes or worsening. And that's why we do the psychological screening in all patients ahead of time. And then the scary risk is bleeding in the brain. And that can happen in about 1% of cases. Fortunately, in most cases where that happens, the patients actually don't have any symptoms. It's just something we can see as a small area on a CAT scan. But in 1 in every few hundred patients, there can be a problem where the bleeding does cause symptoms or causes lasting problems. It's not common, but it is something that I mention to patients. Another question I've had is, when you're thinking about DBS, what kinds of things should you consider asking your surgeon to decide if this is the right thing for you? We've touched on some of this, but I like to go over with patients which of their symptoms is likely to get better and which won't. Do you think we should treat both sides of the brain? One side of the brain controls the opposite side of the body. So sometimes in DBS, we'll put a probe on both sides of the brain. Some patients really only have symptoms on one side, in which case we'll treat just one side of the brain. And in some cases, both sides are affected, but there might be factors that lead us to choose just treating one side at a time rather than both sides at the same time. So I think that's an important discussion. Should I get a rechargeable battery? So some DBS batteries can actually be charged through the skin. Some don't require that charging, and you just get them replaced every 4, 5, 6 years. And understanding which is a better fit for you, I think, is important. You should ask your surgeon how they perform the surgery and what to expect in the operating room. Are you going to be tested in the operating room, or will you be asleep? And should you take your medicines, your Parkinson's medicines, on the morning of surgery? I don't have patients take them on the morning of surgery so that I can see their tremor and other symptoms that we're trying to address. But some surgeons have the patients take the medicines. And then, just questions about basic post-op care after surgery. What should I expect? What should I look out for? These are things that I think are important to bring, to your discussion with your surgeon when you meet him or her.
She's like, I don't know. It didn't flush the last time I was here, so.
And then after implantation, after surgery, there's an initial programming session that happens with your neurologist, usually about a month after the brain part of the surgery. And then usually a few sessions to get the settings of the stimulator just right. This is a process of trial and error, and we don't know the settings that will be the best fit for you. And we like to usually start them pretty low and ramp them up to make sure that you're tolerating them rather than go too quickly. So I think we have a little time. I want to be respectful of your time and certainly allow some time for questions. So I wanted to talk a little bit about what are the frontiers of surgery for Parkinson's disease? What are some things we have now that we didn't have 5 years ago? And what might be coming down the pike in the future? So one thing that we have nowadays is much more advanced leads or probes that we insert into the brain than we ever had before. We now have therapies that allow us to stimulate probe but in specific directions. So the wires that were made decades ago really only allowed us to stimulate in every direction. And now we can really target the therapy if there's a particular part of the brain that we want to stimulate. And that can matter because sometimes when we place these electrodes, there are critical structures nearby where we know that the electricity can cause side effects. And so directional stimulation really allows us to kind of push or steer the electricity towards the structures we want to stimulate and away from the things that we know cause side effects. And there's evidence that this kind of therapy translates to better outcomes for patients and less need for revisions or changes in the therapy down the line. As I talked about, surgical robotics is now changing the way we can do surgery, as are other technologies for placing the leads. I love using a robot. I think it makes the procedure much faster. It makes it more precise and less invasive for the patient. Really what this is, it's a robotic arm that has kind of millimeter accuracy. So I kind of show the robot on an MRI scan where I would like the electrode to end up. And I show the robot where the patient's head is in space.
Is this DBS surgery?
I'm getting a little bit, somebody may need to mute their microphone. But the robot really allows me to aim the electrode into the brain with millimeter precision. So it takes a lot of the guesswork out. It takes a lot of the room for error out. The robot doesn't perform the surgery. In fact, it actually never touches the patient, but it basically aligns me to my target with a very high degree of accuracy. And I've been quite happy with it. And what that means is that a lower chance of bleeding, less time in the operating room, and a smoother experience for the patient, in my opinion. We now have technologies that allow us to listen to the brain. So not only to stimulate it, but to actually listen to some of the signals that we're seeing and potentially make changes in the therapy as a result of that. And then kind of along the lines of the slide I showed before, but some ability to send the current down the electrode in interesting ways that allow us to shape it and steer it to try to maximize the benefit and avoid side effects. There's also research on new surgical targets. So I mentioned that there were 2 before, one of which is called the subthalamic nucleus, or STN. There's some evidence that a target that's a little behind it can actually be quite helpful for patients with tremor dominant symptoms. And this is something that's in use in Europe, but not as much in the United States, but has, excuse me, clinical trials underway. Additionally, we now have alternative therapies for patients who have mostly tremor symptoms, and I wanted to talk about two of them. So sometimes I meet a patient, particularly older patients, those that may be a little too old for something like deep brain stimulation, whose dominant symptom is really just tremor. And for those patients, going through DBS may be too much risk or trouble. And so I might recommend another procedure called a thalamotomy, which is where we burn a little spot in the brain. Michael J. Fox had a version of this surgery, but we can do it in different ways. And one of them is with Gamma Knife, which is a platform that allows us to perform the procedure without any incision. It just gives tiny focused beams of radiation all to a single spot in the brain to try to damage that brain, to damage that spot without any need for, going to the operating room or an incision. So Gamma Knife, I think, is a nice therapy. It's very gentle. It's outpatient. It's just a couple hours, but it does have a delay of a few months in the relief and the tremor. Some of you might have heard of MRI-guided focused ultrasound. This is a therapy that we use mostly for patients with tremor. We're getting one with Swedish just in the next few months, but there's good evidence that you can also apply this to patients with Parkinson's disease. But again, I really steer patients towards DBS, and I consider this mainly an option for patients who really only have tremor and don't have those other symptoms, or for some reason can't have deep brain stimulation or DBS. Just some comparison of those two therapies. But with that, I wanted to wrap up. I do have a website that I maintain. We could send it out. It goes over all things that we discussed today, has some images, has some videos, and I write the content, and so I can trust it, but it gives a little more information on DBS and some of the other therapies that we discussed. So welcome you to check it out or browse at your own time. This is just some screenshots from the website, but with that, I wanted to wrap up and make sure that we carved out some time for folks to get any questions if you have any.
Thank you, Doctor, for that very comprehensive explanation of DBS and also covering some alternative therapies and procedures for tremor not related to Parkinson's. Before we turned it over for questions, I wanted to introduce another person attending the webinar today. Her name is Cindy Kuykendall. Cindy, would you like to have a few words with our attendees before we turn it over to questions?
Sure, thanks. I'm Cindy Kuykendall. I work for Abbott, which is one of the 3 companies right now in the United States that offers DBS therapy, and I work closely with Dr. Mian at Swedish. And first of all, just thanks for the opportunity to have the educational program today. One thing I will forward to the group when we're done, and Meredith can send it on or Adrian can send it on, is that Abbott just recently got FDA approval for what's called virtual remote care. So we can actually now program the device following surgery remotely over Wi-Fi. So it's enabling people that live a distance from the hospital or just want the convenience of being able to have kind of intermittent programming sessions from their home versus always having to go into the clinic. So there's some new technology on the programming side as well. And I'll make sure and forward to the group that information if you want to do some more research on that. So thanks.
That's a great point, Cindy, and that's my oversight. I haven't updated the slide deck in a couple months, but this is a great new technology from Abbott that allows patients to meet with their neurologist by video and make changes to the device. So as we mentioned, it requires upkeep just like any other implant or device. And some patients, I meet patients from all places in Colorado, from neighboring states, and sometimes they don't live right near a neurologist who has experience in programming a DBS system. And so it's a really nice therapy that allows patients to meet remotely, to make adjustments so that they don't have to, travel. I think, one of the silver linings of the pandemic is that we've discovered the power of meeting people remotely through Zoom or some of these other technologies. And we're just starting to understand the power of that.
Yeah.
So it's a nice new technology. And thank you, Cindy, for reminding me to include that.
And one thing I'll just mention is that they were still reviewing the codes. One of the silver linings of COVID has been that we've gotten approval to actually code and bill remote visits. So the DBS programming codes right now are being covered by insurance companies, and we're looking at extending that coverage into 2022 and beyond. So I know the Parkinson's Association actually had some information on that on their website. So any support, any lobbying we can get to continue this remote care is great. So we're working on that, and hopefully this is just the beginning of what's to come.
Yes, remote care. It's so important and has really the norm for us. So
Yeah.
let's open it up to our attendees for any questions. Please go ahead, ask the doctor or Ms. Kuykendall any questions that you might have.
How do you ask a question?
Hi, Matt. This is Michelle Gutierrez. My question is just to solidify one of the points you made was that you have your patients stop meds the morning of the surgery. But before that, is there a before period of discontinuing medications before the surgery, like 6 weeks, don't be on the levodopa or, something like that?
Oh, great question. So absolutely not. I have patients continue their medicine up until the morning of surgery. And then we restart the medicines as soon as the surgery is done. So the purpose of this, the intention or the goal is really just when you're in the operating room, I want to make sure that I can see the symptoms that we're trying to treat. And if you're in a really good place at that moment because of your medicines, sometimes it can be kind of subtle. And so I like for things to be really obvious, but it's really just a narrow window of a few hours where we have you off your medicine. So certainly not for weeks or anything like that, but good question.
Norm, I believe you had a question.
I do. I'd like to know if stem cells become available, how that affects the DBS.
Yeah, so I think, stem cells is kind of, or something like that. Gene therapy is kind of the holy grail in Parkinson's disease, because the idea is if we can somehow either inject cells or change other cells in the brain in such a way that they produce dopamine, that would ultimately kind of get at the root cause of the problem. So there's been a number of kind of early pilot studies that are looking at that. Nothing is in large scale clinical trials right now, or certainly in clinical use. And so I think we're some ways away from that. But the idea maybe someday would be that instead of a stimulator, we inject a gene or stem cells. But I think at present, that's pretty far away from being clinically used. And it's hard to know because it may turn out that that is a partial solution, but patients still have enough symptoms that we need to think about therapies like.
Whoops, we haven't.
Yeah, the doctor is frozen on the screen for me too.
I think he might have even dropped off. Oh, Matt, Dr. Mian, are you there? Well, right in the middle of that answer too. It looks like he's dropped off.
You dropped off for a minute for me, but now you're back, so maybe he'll come back. Here
Okay, there
comes.
he is. Doctor, you dropped off for a minute.
Might be my connection. I apologize for that. I don't know. Somebody's maybe cutting the power lines around.
Would you, it
Maybe
appears
just
that
turn
you
the
off
camera
again.
off and then just use the audio.
That
Okay,
might
well,
help.
I can hear you guys. I don't know if you can see me, but
Can you turn off your video? That might save some,
sure. Other questions?
could you repeat the answer for Norm about the stem cell?
So, yeah, I don't know how much got cut off, sorry, but so stem cells are something that we're all hoping for, but are in just very early pilot studies right now. There are no large clinical trials, certainly, and so stem cells and gene therapy in general are still a little ways away, but we're all very hopeful about that. And someday, who knows, it may replace some of the therapies we discussed today, but it's still a very much kind of limited studies and fairly experimental.
Do these studies need any volunteers?
I'm sure. I don't know of an active list of those that are enrolling,
Okay,
but
we can keep in touch with our local Parkinson's Association to find out more about that, I imagine. Other questions for the doctor?
One. It's my understanding that anesthesia and Parkinson's is not always a very good pair with surgery. And so I guess part of my question is, so do you use other kinds of anesthesias? Do you not use these anesthesias that cause problems? And the other part of my question is there kind of an age factor? Because a lot of people with Parkinson's are older, not everybody, but you know, a lot of times surgeries cut people off at certain ages, you know, transplants and different things. Is there anything with Parkinson's on that line?
great questions. So to answer the second one, I don't have any kind of age cutoff. I will say that, of course, as patients get older, the risks of any kind of surgery increase a little bit. And so, you know, I've implanted patients over the age of 80. I would say that we have to be pretty careful once we get towards that age and above. My typical patient is probably in the 50s or 60s, but I have a number of patients in their 70s that I've implanted. And sometimes just usually over the age of 70, I'm pretty insistent that we treat just one side of the brain at a time to make sure that we're not putting the patient at too much risk of cognitive problems. But no, I do not have an age cutoff. And sometimes it just means that I factor in additional things that I think make the surgery a little safer. To answer your first question, I agree. So I think that anesthesia can be really tough on patients with Parkinson's disease, especially prolonged and general anesthesia. And that's part of the reason I do my surgery awake. Number one, so that I can test the patient, and number two, so that we avoid the problems of being under anesthesia for, you know, sometimes 4 or 5 hours, which is not trivial on a patient with Parkinson's disease. So that's why I think I've had some success with patients doing pretty well and going home pretty quickly after surgery. Unfortunately, for the battery procedure, for placing the battery the first time, we kind of have to do that under general anesthesia just because it's pretty uncomfortable. But that said, the procedure is less than an hour. It's pretty short, and most patients do just fine with that. To my knowledge, there's not data, and I just haven't looked into this, but I'm not aware of any data that suggests that one type of anesthetic is more harmful or risky than another type of anesthetic for Parkinson's disease. And so, but we do use general anesthesia for the initial battery replacement. If you've had a DBS system for a long time and you just need to come in to get it replaced, that is just done under sedation. That's not general anesthesia. That's a very short procedure, about 20 minutes. So yes, I do try to minimize anesthesia to every degree possible.
Other questions? Any follow-ups?
Yes.
Go right ahead, Norm.
I'm wondering if one of the risks that I've heard is the fact that people lose their ability to communicate verbally. Is that how big a risk? In fact, I've heard that there's a clinical study on that now that they're doing on patients that have gone through DBS.
So good question. I think, so that relates to one of the cognitive side effects that can happen from DBS. That's something called verbal fluency. And studies of patients with DBS have found that, yes, sometimes there are changes in verbal fluency. So part of the reason we get the psychological evaluation beforehand is to understand who might be at risk of those problems. I think there's a big difference between somebody who takes a neuropsychological test before and after surgery and has a small difference that's not clinically meaningful or doesn't change their life versus somebody who's very affected. And so statistically, you definitely see that there's a slight difference before and after surgery, but in the vast majority of patients, that doesn't translate into something that they or their family members notice. Now, if we're not careful about who we do the surgery on, or we do it in certain ways, you can cause a change in verbal fluency that is noticeable. And that's all about this psychological screening and patient selection that I mentioned, trying to choose patients carefully. And when you see that patients have existing problems with verbal fluency, doing the surgery in such a way that you minimize the chance that it becomes more prominent afterwards. But that is true. But I think the idea that patients lose the ability to communicate or cannot be communicative or speak, that is not certainly expected. That would be a catastrophic outcome, in my opinion. And I do not have any patients who've had that kind of thing happen to them.
We just literally have a few seconds left. Any other questions for the doctor or perhaps for Ms. Kuykendall? Cindy, would you please text me your or message your email address to me just
Sure.
for Meredith's use?
Sure.
And any other questions for the doctor? This has been a great session. Everybody, let's give the doctor a round of applause. This has been wonderful. Thank you so much for taking the time. It's been
Definitely.
I think it's been very enlightening, and I've seen a few of these presentations over the years. So thank you very much. Especially enjoyed the photos of the operating room. I think the more we see that type of thing, the more we can accommodate ourselves to that environment. You're in it every day, but we're not.
No, I know people find that fascinating, and thank you guys very much for having me. I really do hope it was helpful, and it's my pleasure. I mean, this is something I'm passionate about, so I very much appreciate you guys inviting me.
Thank you, thank you. And to our Parkinson's Pointe participants, we'll look forward to seeing you in July. July 24th is our next educational session. And I'll just leave the meeting open for a few more minutes in case anybody has any additional questions, but you can log off if you like. Thank you very much. Goodbye, everyone.
Thank
you.
you.
Happy 4th.
Happy 4th. Thanks, Merritt. Thanks, Cindy. I got your email address.
Yeah, I'll send, shoot me yours. I think it was on, or actually just give it to me, and I'll send those follow-up educational pieces if the group wants them.
I just messaged it to you.
Oh, I got it. Yep.
And also it would be very helpful to send them to Meredith. She likes to put those in the main emails.
I will do that. Thanks again, you guys.
Okay.
Thank you.
Great session and great questions, everyone.
Goodbye.
Bye.
Oh, you gotta heard of this guy. He's 2019. It's interesting that she does his patients